contralateral side, there's a little bit of mass, but there's a transverse process, and this is sort of hidden, or this is the transverse process. We can see a little more clearly. So I have an L5 vertebral body LSTV, unilateral or bilateral?
Unilateral.
It's unilateral. Which side in anatomic position?
The left side.
Left. Okay? Now, I don't think there's any value in saying Castelvi type 2A or 2B. Okay? Because I've been doing this for a while and I still can't remember. I don't use that in my RAD reports. I simply say pseudoarthrosis on the left side, hypoplastic disc, LSTV. Okay?
Yep.
Now, treatment-wise, back in the day, they would simply inject this with saline and there would be relief of pain. These days, you go to the chiropractor because you have back pain. If you manipulate this area, do you think you can relieve the discomfort? You may or may not, but if you're not, you have to explain to the patient why you were sore for a couple days. Or, patient, I'm sore for a couple days, what did you do to me, doctor? The other guy didn't do that, or the other gal didn't do that. Well, because they understood that this is present and they did work elsewhere. Okay? Does that make sense?
Yes.
All right. What else do I want to tell you? If you can't make this decision, this doesn't become clear, all right, which view that we've taught you in lumbar spine radiography can you use to make this more optimal to your eye?
The shot.
Another x-ray, but which one?
Lumbar spot.
Which spot? AP spot. Because the AP spot will show you this area optimally. It'll also show you the pars region. Remember the discussion about the oblique views? It'll show you the transitional lumbosacral segment more clearly. So something you thought was there should clean up and become more easily recognized on the AP lumbosacral spot view. I use this all the time. And if you sit with me, we can invert this. We can make this black and white. So if I'm not sure I'm seeing it, I can change the physical parameters of it, and now it becomes visualized. If I'm not sure, I'm going to do the same thing I'm telling you to do. AP spot view. If the doctor doesn't know how to do it, don't worry about it. I'll email you the instructions. You know, you've been trained, you know what to do. Now, they're not all as obvious as this, but this is an example of a unilateral LSTV. Which level? Well, we counted. Okay, so I still have to count. 1, 2, 3, 4. This is 5.
Mm-hmm.
And I can label it at 5. Now, why is that important?
Just depending on sacralization and lumbarization.
You need to know at which level.
Yeah.
This is on the left side. Okay, you may want to do some work on the other side. You also want to know that it's not an L4 LSTV if they have only 4 lumbar vertebral bodies.
Right.
This business of sacralization for us is 4 typical vertebral bodies. So if this wasn't there, I have 4 typical lumbar vertebral bodies, sacralization, and that's consistent with some of the other information I got from the other articles. Okay? I can have 6 classic lumbar vertebral bodies. We call that lumbarization, and everything in between. So we just describe simply. All right?
Mm-hmm.
Now, I don't know how old this patient is, but going forward this way in terms of a timeline, what were the complications that came from the 210 article that I had you read? That you told me. What were the complications?
Stenosis.
Clinical findings, stenosis. Good. What else?
Something about the vertebra above, I forget.
Nerve entrapment.
Nerve root entrapment. Okay,
Yeah.
if I have osseous abnormality, I can have concomitant nerve root or soft tissue abnormalities. Okay, so
Yeah.
nerve root entrapment. What else? Stefano mentioned the disc. The disc above the level of the transitional is likely to undergo changes because of this pseudoarthrosis, or if it's incorporated in the sacrum. So if this isn't there, this is a fixed unit that puts other biomechanical stresses, is what the article is saying about disc abnormality above. So all I think is, at some point, when this patient goes this way in terms of timeline, if they have radicular signs and symptoms, it may be because they are developing now a disc lesion at L4. Some of them do, some of them don't. If they say, I don't know what you've been doing, it's been working, but now it's not working anymore, I've got pain into my leg, big toe. It's time for the MRI. Why?
Yeah.
Because we want to evaluate for a disc lesion. If they don't get it, that's good for you, it's good for them, but if they get it, it's because you knew about the
Yeah.
issue, okay? And the other article, or the clinical finding was contralateral facet pain. They may have more pain on this side, okay? And then somebody kept reading till the end of the article, or a couple of you did, and said, wrong level surgery. Is that important?
Yeah,
Absolutely,
big time.
okay? Now, if your films are AHARA, let's say stellar, you can send a CD, and they can say, okay, it's at the L5 level. If they don't have good images, they're gonna do plain films and the MRI to make sure exactly what level they are dealing with when they do their surgical intervention. Now, why did they point out wrong level surgery? Has it happened once or twice? Okay, it's happened. Has it been that have patients gone to the chiropractors and they didn't know which level to adjust?
Oh, God.
Of course, happens all the time, okay? But if you want your associate or the person who's filling in for you, you need to say, look, this patient has a unilateral pseudoarthrosis. I would suggest you don't manipulate their L5, S1 region. Just telling you, okay? If they go ahead and do it, it's on them, right?
Mhm.
Okay? Does that make sense?
Yes.
Now, the other thing that the 210 article pointed out is, at that time, they said, we don't know whether there's a strong association between transitional LSTVs and back pain. The article that I'm gonna talk about a little bit later says 2016, 2016, 17, somewhere in there, it says, yes. These that have pseudoarthrosis, whether it's unilateral or bilateral, are more likely to have back pain, which makes sense. Now, let the academics argue in their research, these patients of mine didn't have it, you have to say, what does your patient present with? And the articles be damned. If the patient doesn't fit this neat little academic exercise, you're gonna still have to deal with it, okay? And now they're doing a lot more work with transitional LSTDs and the prevalence of them in a particular population, military recruits, or what does it look like on MRI? In other words, it's developing as we go along. So it went from not sure whether it's associated with back pain when type 1 or unilateral and bilateral pseudoarthrosis, in fact, are 99% associated with back pain. You can take that to the bank and use it. So now when you get your first case, you have to find out. And all they're saying, Berlotti's is what? LSTV and back pain. Dr. Berlotti wanted, not anonymity, what did he want? Fame? 15 minutes worth of fame, right? There's not gonna be a Dombrowski x-ray finding. Okay? So, present it to the chiropractor. And I saw a block vertebral body this morning. You're gonna see it for next Tuesday. All to point out and emphasize the fact this stuff happens, okay? All right. 1, 2, 3, 4, 5. What do you notice? What's different about 5?
It's bilateral.
Bilateral? Is it a clear,
Pseudoarthrosis.
easy pseudoarthrosis to see?
It's clear.
Yes, no. So if you're confused, what's the go-to examination? Just do an AP lumbosacral spot U, and if it stays identical, these are incorporated into the same. In other words, it's a bony mass.
So it's
You
sacralized.
cannot manipulate that even with a drop table.
Yep.
Okay? But what this points out nicely is normal disc height. Would you all agree this one is different?
Yes.
That's what I mean by hypoplastic disc. So depending on which one I see first, this is the clue. I know I can expect some variation of this thing. I don't worry about what Castelvi type it is. It's bilateral. If I do my AP lumbosacral spot view, I'll be able to tell whether there's pseudoarthrosis or not. Fair enough?
Oh, yeah.
Got it. Well, or that's how it works. Okay. Now, the next thing that can happen is, if you can't tell that this is T12 by virtue of the ribs, which can be asymmetric from side to side, what would be a prudent, reasonable thing that you can do in your office to help you?
Count the ribs.
Count the ribs, but you've only got the lower ribs. We're assuming that this is T12. What could you do imaging-wise in your office based on the views that we've studied and taken and had you demonstrate? Which view would we put the cassette 3 fingers above the shoulders?
Oh, that would be AP thoracic.
AP thoracic, just do a thoracic. And if you can count 12 all the way up to 1, you know there's 12 rib-bearing vertebral bodies. Okay, this has to be T12, 11, and so on. In other words, you have to have a baseline. So if I was in doubt, I would just take a thoracic and go from there. The last LSTV I saw, they had surgery here, I couldn't tell whether it was 5 or 4. Now we're in the gray area. We just say at the lumbosacral junction, there's an anomalous or an LSTV. We don't try to say 4 or 6 or whatever. We can't do that. If I had to do that, I would go into the same routine I just described. Take the thoracic and go from there. It's not that simple. Some people have 11 thoracic rib-bearing vertebrae, some have 13. But if you can count 1, you can figure that out. Everybody with me?
Yes.
Okay. So more examples of LSTVs. Unilateral or bilateral?
Bilateral.
It's bilateral, but be careful. This one has, there's a pseudoarthrosis here on this side. If you can make one cortical margin traverse another cortical margin, it's this. Okay? So in this case, if you weren't sure, do an AP lumbosacral spot view. But this cortical margin goes from here, crosses this cortex, so it isn't a pseudoarthrosis. This is probably a pseudoarthrosis. And the standby examination, if we wanted to argue about it, you say tomato, I say tomato, let's answer it. Let's get an AP lumbosacral spot view, and then it should be optimally, easily visualized. Okay, now look, transitional LSTV. Isn't it more than coincidence, or it's more than coincidence to me that this SI joint shouldn't have this band of sclerosis? That's already early degenerative change, more on this viewing left side. So that band of sclerosis shouldn't be there. It makes good common sense that because they have a pseudoarthrosis, they might get changes in the SI joint. So if it can work cranially, it can also work caudally. This is this patient. This is what this patient has. Okay? Now, my suspicion is they're going to have episodic back pain as they go forward in their life. It's that simple. That should make you feel good because you're going to have patient security, right? Off and on, you're going to need care. All right?
So again, here, on that picture, on that view, if you only had that view and you had no other views, you wouldn't call out a level here, because you really don't.
No, I have to know something. When I put on, this is 4, I expect 5.
Right.
To tell me 5. Now, why do I do that? Because you're going 5 to 6 to 7, all the way to 9. When you do a report, the part they read is the conclusion or your impressions. And on that information, if you have 5 lumbar vertebral bodies and you can count 5, you would want to put the level.
Got it, but here you can't count
can't.
them, so.
No, we just say
You would just
lumbosacral.
say lumbosacral junction.
Yep, LSTV, describe it. Okay?
Describe,
Go ahead, Nan.
describe how you said the other side again, one's a pseudoarthrosis, which clearly has the joint there. What's the other one, what would you call that?
I just call this a bilateral or a spatulated transverse process. Okay? But
It's still connected.
it looks like it's connected, but this cortex crosses this one. So it makes me think it's not a pseudoarthrosis, but I wouldn't be sure unless I did the same thing I'm telling you.
So it's spatulated.
You can't make decisions if you don't have all the information. So in this case, my recommendation would be, let's get an AP lumbosacral spot view. In the clinic, I can dictate what they do if there's the gray area. Okay, did everybody follow that?
Yeah.
In other words, that's the big thing about radiology. Blacks and whites,
Yep.
but this huge bit of gray. Okay, so if there's a question in your mind, just describe things to the best of your ability. Okay, and if you have a level, if this is L4, clearly you'd say this was a 5. If there's no 4, you just say lumbosacral junction. Okay.
True.
All right. So this was all about, they're all rocks, right? Yes?
Yes.
But some of them are different than others, okay? So that's the point. There's LSTVs that are unilateral, bilateral, that's just where I was going, that a visual. All right? Okay, so the project. We went through this, okay? So this is here, so this is what?
Spinous process.
Identified L4, so 5.
5. The interesting thing where the arrow is, there's a pseudoarthrosis, but understand it's a false joint. But there's also more white here. This is undergoing degenerative change. So some pseudoarthrosis, were, depending on the stress of the patient and how their activities of daily living, there's white here, which is not normal, and I'm just pointing that out to you. That comes in Arthrotides class. But there's no whiteness here. So depending on the activities of daily living, you can cause degenerative change or accelerated degenerative change with this patient. Now, if I had included the lateral, we would make a decision about whether the disc is normal in height or whether it's decreased. But when it's decreased in height, back to, that's your first clue, okay? And most people did this well, all right? I'm just introducing the Krispy Kreme donut idea. The nucleus pulposus is this, the dark area is what? The disc. Of the disc, which component of the disc?
The annulus
The annulus
fibrosis.
fibrosis. Dark for the annulus, this signal intensity for the nucleus pulposus. When you lose this signal, that means it's losing water content. I'm getting ahead of myself, but it's losing water content, and we call that desiccation.
Okay.
All right? And as the patient ages, this height, there's a particular height to this will also decrease. So now you've got the disc aging, and you are not surprised that some of the material, the annulus can get tears within it, and then some of the nucleus pulposus material can seep into the disc, into the cracks, and then you can get the beginnings of a disc herniation. That's how it works. All right? Now, the reason I want you to think about this, which is what?
The PL.
PLL. Notice the normal concavity to the posterior aspect of the vertebral body. That's normal. And as this disc herniates posteriorly, it will push the PLL out of the way. And didn't the PLL, at the disc margin, wasn't the PLL this is discal material here, right?
Mm-hmm.
Okay? So the PLL protects the central portion of the disc. So if a disc herniates or gets bigger and larger, will it come straight posteriorly, or will it take the path of least resistance and go adjacent?
Path of least resistance.
Paracentral. Okay, so when you're looking at an MRI now, as we get developing this, most of the lesions are paracentral. There's an anatomic reason for it. The PLL protects the disc immediately behind it.
Mhm.
When this disc pushes this PLL, it's going to cause encroachment onto what? Spinal canal and cord.
Yep.
Okay? And we're way ahead of ourselves, we're just setting the stage right now. All right? So the idea is always to find something that you know to be normal, okay? And compare it to the abnormal. And the other reason I do this is how National Board Part 3 works, plain film imaging. Plain film imaging. And you're hoping that the answer that they ask about this is one of the multiple choice questions. Okay? So there's a method behind my madness. All right. So 210, they said, possible association with back pain. I will post for you the URL, or maybe I have it, this one, okay? This was 2015. There's the, not the URL, but if you just put this in, you'll get the same article, all right? And they always cover their bases and say more investigation is needed, okay? But what these people are now saying is, yes, depending on which camp you're in, if you have unilateral pseudoarthrosis or bilateral arthrosis, there is a much higher association of back pain, okay? The story's to be continued. And they're comparing what do we see on MRI, what do we do all, which patient cohorts are we comparing against? All right.
I got a question.
Yes.
Can you go over the difference between the morphological versus the what you call it?
Morphological is, okay, this is a bilateral spatulated transverse process. That's morphology. What does it look like? Clinical significance or clinical findings.
Okay.
Okay. What else did I want to chat about? Lost it, okay. All right, what you're probably most interested in is this. So the written 2 modular exam is next Thursday, yes?
Yes.
Week today. And I think I got it right on the announcements, 4 to 5
Yep.
for those people that are with us. Okay, and then we go to the lab and do rad positioning only. So you'll do AP and lateral is a choice, right, and left anterior oblique is a choice. Posterior obliques are a choice, and everybody's favorite are the spot views. Okay, but I'm changing it up. We'll see how you do in lab. It could go from 5 minutes to 4. Everybody's able to do it in 5, and your standing round board, we'll knock it down to 4.
Okay.
All right?
Mm-hmm.
Okay, as far as the written goes, the factor sheet, what was that all about? And I'll show you what it was. You need to know what this is, okay? When we say quantity of electrons that's associated with MAS, it's not gonna be that simple, but you get the idea, right?
Sure.
Okay? Causes blacks and whites, not radiographic contrast. Radiographic contrast is all about KVPs, all of these synonyms. Does that make sense?
Yep.
Okay, so if I go back, factor sheet, scatter radiation, that was what happens inside the patient's body. Coherent, scattering, that PowerPoint presentation, all right? What I didn't include this time is no questions on rad biology.
Mm.
Okay, that would come in next semester, all right? Okay. 20 multiple choice questions. I remember saying we'll revisit the questions that were problematic in the first exam. We're doing it respondus. I can almost guarantee you, as best as I can guarantee you, there's gonna be 20 questions.
Oh, yeah?
Because I have to type them in. Okay, 5 cases with lumbar normal variance. We can make the last one comprehensive. Okay? Questions on this?
What'd you say, make the last one comprehensive?
Well, any and all normal variants, cervical,
Gotcha.
thoracic, and lumbar. This one is lumbars only.
Gotcha.
Is everybody here that needs to be here? Okay. Are we clear? We're good?
And you have the other cases in program resources again, or no? Or was that the one you just showed us?
Not sure you,
So like the last exam, you had something in program resources where you listed a certain amount of pictures, and you said,
no.
okay,
So what I wrote in program resources is something called axial normal variants.
Gotcha.
Cervical, thoracic, and lumbar.
gotcha,
All of them. This time we're honing in and concentrating on
lumbar,
lumbars.
gotcha.
And to Elle, who's not here momentarily, but to Haley, I sent out a set of lumbar normal variants,
Okay,
okay, that I want you to be very familiar with. Are there others? Yes.
good.
I sent you this much, okay?
Got it, thank you.
All right, but more is not necessarily better. If you can't recognize a lumbar block vertebral body, we're stuck, okay? So if I show you 99 others, you're gonna say, I don't even recognize this one. So again, there's
True,
attitude.
sure.
Any other questions on the topics?
No, sir.
You said, I'm sorry, the normal variance for the lumbar are you sent to who?
I put all the normal variants of the course and to program resources. The lumbar the lumbar spine only ones I sent to Al and Haley for distribution on Instagram.
Oh,
You're not at a disadvantage if you don't look at Instagram. Then you need to look at the actual normal variants PDF in program resources.
okay.
Whichever way floats your
Yeah,
boat. If I was you, I would look at both. Okay? Why? Because the first slide we showed you, okay? This is the most common lumbosacral normal variant I see in its various iterations and forms.
mm-hmm,
And the reason I have you put the article, and if you wanna hang on to the next article for your digital vault, you're not gonna remember all this stuff after graduation, but you remember that you put something in there in your digital vault where you know where it is, so when the time comes, okay? So when your script says, I want an MRI because the patient has an LSTV and I'm worried about disc lesion above, from the article that is referenced on, if you write that, they know that you know.
mm-hmm,
If you just tell them, well, I want to rule out abnormal pathology, just like any other chiropractor who lumps all their stuff into one bucket. You want to be different, you want to be unique, you want to prove yourself, and then they will think about you being the authority so that you get the referrals when their patients or their crew has mechanical back pain, they know to send them to you. And the converse is also true. I'm not even going to go there. Okay? Questions on LSTVs? Now, I'll keep showing you LSTVs, okay, until I think you've got it, until it becomes automatic. So you'll see at least a dozen more cases. Okay, they'll be mixed in with other stuff, but, okay, we keep circling around. This morning, or just before I came, I saw a nice cervical block vertebral body of C2-3. What do you think I said? What do you think the decision-making process was?
what do you mean,
What
like
does
no
that block
adjustment?
vertebral body look like in the cervical spine, word picture?
What does it look like? You said at 2 and 3?
See 2 and 3.
So it just looks like the top one's good and 4 is bad?
Well, what are the radiographic characteristics of a block vertebral body?
Fused facet joints,
Fused facet joints?
fused.
So-
Spinous processes,
No discs.
No, just,
no disc space, yeah.
Okay.
Anterior
boss
concavity.
brace, it had one of those, it had a remnant disc space that was calcified, there was no, there's the facet joint, in 2-3, there was no facet joint, it looked like just one line, so there's possible
Transverse,
fusion,
yeah.
or,
okay? And the spinous processes was one big mass, you're gonna see it.
Yep.
So what are we gonna do next step? The view that we showed you in cervical spine, flexion.
Yep,
If
flexion.
there's opens up,
Then it's not blocked.
Totally
Other than-
blocked, you cannot manipulate there, okay? But then I've said, if it's totally blocked, posterior joints, I forget how old this patient was.
You get the degeneration and
56, I
the,
think. Okay, they're gonna develop degenerative changes somewhere else. It depends. Is this the case that does, or is this one of the lucky ones that doesn't? So we're following it. So you're perfectly entitled to, 5 years from now, take another lateral, and if that doesn't change, you're good. If you see degenerative disc disease, that's your first clue.
yeah.
Now you're making a different decision. If there are radicular signs and symptoms, you know it's time for the MRI.
MRI,
That's how the game works in my mind. Okay?
yeah.
and if it was congenital, we wouldn't see the curve,
The anterior concavity, you mean?
the anterior concavity, correct?
Correct. Now, if we're going to, if it's a surgical one, you should see the scar, okay? And if it
Oh.
was surgical or acquired, knives or robotic knives leave straight edges, okay? So they did this. So there are ways of telling, but I think, and the other thing is, if they did surgery on the, in this lower, whatever level it is, you're gonna see surgical sutures, little metallic
Mhm.
things, okay?
So cool.
Well, I think it is because now you get the width and the breadth and the depth of radiology, right?
The meat and
I was
potatoes.
confused. What's so complicated about this? Oops. Depends on how far you wanna drill down. Okay? All right. Let's go with this next one. Does yours look the same as this? Pretty well?
Yep. I think so, yep.
I hope so, because I don't want to. Close enough.
Yeah,
Okay.
it's
Yes, the
Ooh.
intro one. Okay. Let's not kill Dr. D just yet.
No, don't do that.
All right, so first lecture, I remember, this is what we want you to do, okay? And if we all do that as a group, we're elevating the boat that you and I are in. Okay, and I don't care what all the other cohorts are doing, I'm saying this boat needs to go this direction. Does that make sense?
Mhm.
Okay, what do I mean by input throughput times? That's the benefit of the digital system. You can take more x-rays of more people in a shorter amount of time. That's called throughput times. Okay, but what's the downside to that? Faster, more patients, shorter period of time,
Let's pay attention to the-
Quality
More error.
goes down.
more error, okay? I'm working faster, I'm working in a shorter period of time, I'm more
Efficient.
efficient, but I'm also
Exhausted, tired.
tired, I'm stressed, I'm on the hamster wheel, okay, and I can't seem to get off,
Right.
okay? When I talk to my girls, or the girls in North Carolina that I taught or teach and taught, okay, they said we can now do 7 views of the cervical spine, 2 thoracics and 2 lumbars in 7 minutes.
Nice.
That's point, shoot, turn, shoot, turn, shoot. Okay, 7, 9, and 2, that's 11 x-rays in that amount of time. That's because they're practicing, they're efficient. But they all say, you know what? I'm really exhausted at the end of the day because my doctor's seeing more patients. It's all about throughput time.
Yep.
Okay? So that's what we mean in the digital world. So we're introducing probably the most, not important, but the most, yes, the most relevant topic for you. These couple lectures on digital imaging acquisition systems are all about digital equipment which you will use in the clinic, all right? And we spent, or I've changed this because we don't need to know, we need to know about DIS. And there were two types, old school, computer radiology, you all want point and shoot, DR, direct radiology, like your smartphone, okay? So I've sort of mixed this and just reduced that, okay? And there's analog X-ray, the conventional X-ray, or old-fashioned X-ray. We all want a DR system for Christmas. Why? It gives me better quality of images, it reduces the exposure to the patient, but the price to pay for this increased throughput time is stress. Okay, you're working faster, harder. What's happening to revenues? Are they going up or are they going down? They're staying
Going up.
flat, they're not going up, they're staying flat, or they're trying to reduce your reimbursement for your x-rays. If you give them a reason to do that, like bad quality films, poor reports, not having markers on that, they've got a huge database of what a normal good x-ray should look like. If yours doesn't pass the muster, they can say, I'm sorry, Dr. D, we're not gonna pay you. What are you talking about? I take good x-rays. No, you don't. There are these and these issues. We'll send you our checklist of all the things that are wrong with it. So you wanna stay in the HARA world. You don't wanna give the insurance company a reason to deny your payment. You wanna be able to say, I do high quality work for these and these reasons, I document it, I can support it in the literature, leave me alone, damn it, and pay me my money. Got it?
That part.
Okay. So, this is what happened. As Medicare goes, everything, all the insurance companies go. So in 2017, they said for computed radiology, cassette-based, starting in 2018, they're gonna reduce the reimbursement rates for taking x-rays using this technology. So over a 4-year period of time, they were cutting the reimbursement rates for this type of x-ray taking that we do not have, 7%. So what does that mean? If you're decreasing reimbursement, you're gonna technically, or you want to x-ray more people, right?
Mhm.
First of all, you have to get them in the door, because you're gonna x-ray more. So now you're beginning to start on the treadmill, okay? What they didn't cut was, they cut the CR side, but they didn't cut the DR side. So what are they doing? They're forcing you into the DR
Digital
side,
world,
right?
yeah.
And the DR side equipment is less expensive than this or more expensive?
More expensive.
More expensive. That's what you're up against. Okay? Everybody wants one. The question is, how do we get one? All right? So you're doing more with less. You're seeing more patients. You're exposing them less. That's fine. You're able to do that more quickly, or your CA is. Okay? You get more consistent image. In other words, there's less retakes. There's more forgiveness with this digital world. Once we show you what the images look like in the RAD lab, you'll understand why. We can manipulate it and make it look pretty. Back in the day, if I didn't have a good x-ray, I had to take it again and figure out how to fix it. That's all gone. So you want that convenience, you're gonna pay for it, okay? All right. And the big thing, why the government even, government even allowed it for the Medicare patients is, this is probably the most important, it reduced patient exposures. We have no more x-rays that are being done at 3-4 seconds exposure time. All right. So we all want one, but what if we can't have one? Because you say I don't have the cash flow, okay? Well, what are your choices? Well, here are your choices. Does this work? Why not?
You can send them for an x-ray if you don't have it.
If you don't have an x-ray, you can send them, but why are you saying I can't live with this? I want to send them somewhere else. Why?
Like in the office, you mean, not having an x-ray machine? Oh, never mind, that's simple.
But why is it not a good option?
Because how do you know what you have in front of you? Sometimes it depends.
So is this a viable option is my question.
Oh, no.
It's
And
fine.
I'm just asking, why not?
You're not Superman, you know?
You don't have x-ray vision, right? Okay, so is every case mechanical back pain, manipulate?
Nope.
No. If a patient slips off the chair and lands on their bottom, they might have a fracture in their sacrum, right? Now, what are you gonna do with that patient? I don't have x-ray in my office. where can you send them?
Hospital, urgent
Okay.
care.
Why not to a DC down
Another
the road who takes good
chiropractor.
x-rays? Okay? In other words, we have to get rid of or deal with this big elephant in the room. The digital system is anywhere between $25,000 and $30,000. Okay? So if there's a DC down the street that takes good image, that's a viable option. Because I want to be able to say to Mrs. Jones, that fell on her bottom, just go down the street and he'll give you a CD and bring it back to you. Okay, does that make sense? It's an option. And I've done this. When I was treating patients, I took x-rays. We took x-rays for 6 other chiropractors in our area. 1 x-ray machine. Okay? And I did that 9 to 10 in the morning and 1 to 2 in the afternoon. That was all it took. I mean, it wasn't like it was swamped every day, but you get good at it. Okay, so that's an option. If this is not an option, imaging center. You have one nearby that you can work with. They want your technical component. What is that? They want to take your plain films, and they want to take your MRIs, because they know conservative care is going to fail in X number of patients, and they're going to need imaging called the MRI. They want that. That's $1,000 a pop. You are their best friend. But what if their images are Nahara? There's another imaging center around that you like better for all these different reasons. Okay? So if you're comparing the images from center A and B, and you like one better, that's the one you want to go with. You have negotiation power and leveraging power. All right? Now my challenge with this for you is, the imaging center takes a 4-view lumbar spine series, so AP lateral and oblique, and you get the CD back, and the RAD report that comes from the radiologist says normal lumbar spine. You look at it, and based on your skill when you're a graduating doctor, you look at it, and you see a radiolucent color on the Scotty dog. What does that mean to you? A radiolucency where there
Pars
shouldn't
in
be a
a-
radiolucency. What does it mean?
That's the pars
Either
interarticularis.
degeneration or a
Pars interarticularis.
pars defect,
Interarticularis.
okay? And a possible spondylolisthesis, okay? Is that important to the radiologist who reads it?
Of course.
Well, he should have read it and said so, but does he manipulate that spot? No, he doesn't care. He just has another set of stacks of films to read. But you're manipulating what? The patient who has the radiolucent pars defect. That's important to you. That's where that sort of breaks down. You can retrain them, especially if they're a young radiologist, and say, I need you to make sure you tell me where the pars defect is and how much anterior translation there is. Why? Because I know that some of them will progress, and I need from your x-ray staff a lateral lumbosacrospalpy. Do you know how to do that? No? Okay, we'll send you some instructions, or I'll send the instructions to you to give to them. That's how important this is. We work with spondylos all the time. Or heaven forbid, what did we talk about earlier? LSTVs, right?
Mhm.
They can do that, okay? But don't assume that this is everything high quality work. All right? And the last option is for you to figure out how you're gonna afford this. Grandma and grandpa wanna give you a Christmas present, that's wonderful. The other option is Dorian's gonna get a mass discount because we're buying 1, 2, 3, 4, 5, 6, 7 systems at the same time.
All my offices then, right?
Yep. Quantity discount, okay? So, what would I do?
All my employees.
I would try this, and I wouldn't think about this until I get a cash flow going,
Mhm.
okay? Until I got a stable base, and then I would do the research, the return on investment, okay? So, what do the guys wanna get when they first graduate? No, not a car. What do they wanna get?
Payroll?
Fancy, not a fancy office, they want the truck,
Oh, yeah, that's right.
right? How much is the truck?
Too much, more than
Too
the,
much.
more than the x-ray machine.
Could be 30,000 plus, okay?
Need money like that.
Can't find a brand new car with 30 anywhere.
Okay. So the minute you know the routine and once it's driven off the lot, this thing is return on investment. This is gonna make an awful lot of money over a 20-year practice lifetime, right?
I'll drive a 20-year-old Honda with 10 million in my bank. I will. Watch.
50 chiropractors, I don't know, you're the only one that would do it. You all want the big car?
I will.
Well, I'm just saying, I mean, you all know
Get
that,
the
right?
point.
Okay, so I would try to do the same thing until I could afford to get my own DR system. I've heard the stories, 5 years into it, some of these kids have reduced their student loans by 50%. And it is doable, but that doesn't mean you can go out and buy the $70,000 truck. Okay, the other way to do it is, all these people that bought the $50,000 truck and wanted the office, they're now going bust, and you can get a DR system. They're hard to find, but you can get a US DR system at half the price, or not $30,000. They overcommitted themselves, and now we suddenly can't keep going. Does that make sense?
Mhm.
Okay. Next thing is, if you take an image, now you can download the image, and it's a digital image. If you have a plain X-ray, you simply take your smartphone, put it on the view box, take the area of interest, and you can email it wherever you want, and they can give you quality control. We can tell you it's not positioned properly, it's too light or too dark, we can fix it. You can't use this as a diagnostic image because the JPEG doesn't have the number of pixels or dots that are on a DICOM image, meaning a patient's image. That's the big thing. Okay? Have I looked at email images? Yes. The one that was last sent to me was a 50-year-old, there was a pathologic fracture. What's a pathologic fracture? The bone is broken because there's a disease process in it. Okay, it's that obvious. I said, your patient needs an orthopedic surgeon. Never mind the argument about the JPEG and the email attachment. You need an orthopedic surgeon for this patient. Does that make sense?
That-
If I have to generate a report, I'm not gonna use the JPEG. I want you to send me the original CD because that's the DICOM image that the numbers of pixels and dots I need to make a diagnostic interpretation. So it's a way for us to convey information, okay? All right, how old? No, last one and then we'll take a break. How old? Okay, motor vehicle accident, what's the date of the examination this?
16.
Okay, who can read these bottom lines here? Front row?
Straightening of normal lordosis may be positional or muscle spasm, no fracture or acute abnormality, sphenoid sinusitis,
Yeah.
findings incidentally noted.
Okay, so this is the key.
No.
This was a young lady, and she was at a stop sign in some dark road in North Carolina, hit by somebody going 50 miles from their back. Okay? She went to a regional center. What was the diagnosis?
No fracture,
Okay?
or an acute hemorrhage.
No, or no, okay, no fracture. And they actually did a CT scan, okay, of the brain, and must have been the cervical spine. All right? About 10 days later, she goes to the chiropractic physician, okay? Now, the mistake that they made, or that mistake they made, it was a good decision on his part. He said, you went to the hospital, I'm gonna request the records. That was mistake number one.
Because now you're assuming that liability, right? Or not?
No, the hospital let the records go, okay, which there may be, but in this case, it bit them in the you-know-where.
Mhm.
Because the chiropractor looks at this x-ray, and we get down to C5, is there an anterior translation
Oh my
of 5 on
God.
6?
Yeah.
Yes, this is the normal interspinous space. This is an increased interspinal space, that's not normal. This is what trauma looks like in the cervical spine. Semester 8, I'm using it to prove this point. You cannot assume that just because they went to a regional center, that this is accurate. They've already let the cat out of the bag, let the records go. Now the doctor has the 70-page records. I have a copy of the 70-page records. And if we wanted to, this young lady could do whatever she wanted, right?
Mhm.
Okay, this was on a Thursday. The doctor said, this is a wet read. He sent this to me and he said, I think there's something wrong. I said, I agree with you. Never in my wildest dreams that I'd have to be thinking about a bilateral facet dislocation. That's what she has. That was on a Thursday. On Friday, and I don't know why he sent her back to the imaging center that missed the fracture, but she was fused. So she'll get an anterior metal plate here. These spinous processes will be reduced, and they reduce them by distracting and putting weights over her head until slowly over the course of the day, this all reduces. This is metal hardware, this is wired, and now she has metal in her body. Okay? That happened Friday afternoon. Why is she a permanent guest of this center?
It's crazy.
Why is she a permanent guest and gets whatever she asks?
Because she has them by the
The
balls.
center.
She can own them if she wants.
This is a lawsuit waiting to happen. I don't
What?
know how it resolves itself, but the point is, that's what happens. You cannot, okay, Imogen, they went to the hospital, I'm okay, I just start manipulating. Whoa, wait a minute. Good clinical decisions, that's you, right? If you're not sure, he made a good clinical decision. I'm gonna make my own decision based on my x-ray, I think something's wrong. He can call whoever he wants, he happened to call me, that's not the point. The point is, I didn't do anything. I just said, yes, there's something wrong, send me the original films, because that's what I need for the x-ray. This stuff happens, is the point, okay? Last one. Same thing. This time the sternum hits the steering wheel. This is, I don't know if this is his chest x-ray or his lateral thoracic, and I may have shown you this before, okay? But if you just look at sternum, 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 there's no space. He's
Jesus.
fractured his sternum. The original center said, you're discharged, you're dismissed. Chiropractor makes his own good decisions, takes a routine, either chest or thoracic x-ray, it's diagnostic. If you put your finger on your sternum, there's not a whole lot of flesh there. This is fractured sternum, and heaven forbid, something should happen where this sharp edge goes posteriorly. Where does it go if it goes posteriorly?
Lungs.
Pericardium, first it has to get through visceral and parietal and visceral pleural, then lung parenchyma, and if it keeps going, pericardium. In the meantime, the lung collapses, air gets introduced, they have a pneumothorax,
Done.
okay? That's not good, all right? Good clinical decisions is the point. You cannot assume just because they went to your favorite chiropractor down the street, he makes good decisions, he may be in a hurry, and everything all the way down the line, okay? All right, I'm tired of talking, let's take a break.